Good morning, everyone, and welcome to Cardiac Sciences Grand Rounds for, is it May 14th today, I think? Today, is it 13th? Thank you, Catherine. It is the 13th of May, everyone. It is our great pleasure today to have esteemed external speaker. Dr. Messika-Zeitoun comes to us from the Ottawa Heart Institute, where he is the director of the Heart Valve Clinic. He is also the CCS lead of the heart valve program within the CCS and has an extensive record of excellent randomized controlled trial involvement, as well as development of percutaneous valve interventions. Today, he's coming to speak to us about tricuspid regurgitation and management of this difficult condition. So, Dr. Zeitoun, welcome to Calgary, and we look forward to your talk.
Thank you very much. My first time in Calgary. I wish I had more time to visit, but next time. Here's my disclosure slide. So TR used to be the forgotten valve, but not anymore, but still remains a lot of questions regarding TR, who you should do an intervention on, why, when, and how. And one of the reasons it has been considered as a forgotten valve is this kind of study. So when I was a resident, my staff told me once, you don't need a tricuspid. The proof is that you can remove it, nothing is going to happen. And came to my mind that the tricuspid valve was like the appendix. You remove it and it's fine. What I would like to demonstrate today is that's completely wrong. And I would like to focus on three situations. First, what is the association or relationship between TR, clinical presentation, and outcome? Two, when you are considering a concomitant mitral and tricuspid intervention, which patients should benefit from that and what are the criteria? And three, when you have isolated TR, when and how to perform an intervention and what you should expect from that intervention. So I will discuss the prevalence of TR, the prognosis of TR, the management of TR. I will very briefly discuss echo, but I will not go into the echocardiographic evaluation of TR. So what is the prevalence of TR? First, TR etiology. You all know that the major cause for TR is secondary TR, more than 90%, and less than 10% are primary, and the most common etiology for primary is endocarditis. For secondary, in this paper, half of them were due to mitral valve or left-sided valve disease, 13% from LV dysfunction, and approximately 1/4 for pulmonary hypertension. And the prevalence has been further defined in this study from the Mayo Clinic. They look at the prevalence of TR in the population. Prevalence overall was 0.55 in the general population. As all the valvular heart disease, the prevalence of TR was increasing with age. Interestingly, the prevalence of TR was exactly the same than prevalence of AS. So it's very common. And another interesting finding, there is a female predominance. More female get TR than male. In patients with LV dysfunction, the prevalence of TR is even higher. You can see more than 1/3 of the patients with LV dysfunction have either mitral or functional TR. Same in patients with degenerative MR. Large study from the Mayo Clinic, more than 6,000 patients. Prevalence of moderate or severe TR was 20%. In the setting of secondary MR, prevalence is even more. If you have moderate functional MR, prevalence of moderate or more moderate TR is 11%. And when you have severe functional MR, 1/3 of the patients have also moderate or severe TR. So clearly, TR is common, and its prevalence is expected to increase with the aging of the population. So now, what is the impact of TR on outcome? We have a lot of studies. One here, published in 2002, showing clearly that there is a worse survival in patients with severe TR, and it's a gradual increase. Same in patients with LV dysfunction from Mayo Clinic. I don't remember exactly the number of patients, 30,000, and you can see a nice increase in mortality with a TR degree. When you have secondary TR, it's even worse. There is a kind of synergistic action. You can see that the worse prognosis is observed in patients with severe MR, severe functional TR. And the COAP trial has compared MitraClip to guideline medical therapy was successful, showing an impact on mortality and heart failure. Some patients had secondary TR, and you can see that having TR gives you a significant number of points, showing that TR in that setting is impacting the outcome. In degenerative MR, again, this study from a Mayo Clinic, a large number of patients, you have an increase in mortality with a TR degree. And this had been integrated into this kind of staging, which comes first from the aortic stenosis. I'm not a strong believer or proponent of this staging. I don't understand why you get LA enlargement after having LV dysfunction. It doesn't make sense to me, but you can see that category 3 is TR, and having TR markedly impact the outcome. So clearly, TR is not benign, it's not the appendix. It's significantly associated with outcome. The next question is TR the cause or just a marker of the outcome, and how to assess that? The problem is that TR is a very heterogeneous entity with a lot of subset, and we have seen that the main etiology is functional. So when you want to assess the outcome or the prognosis linked to TR, you need to account for the underlying etiology. How to do that? We have different ways. One is to perform statistics. In this seminal study from NAT in 2004, they observe again progressive increase in mortality with TR degree, and it was persistent after adjustment for age, EF, RV function, RV size, systolic pulmonary pressure. Another study from the Mayo Clinic, they match patients with LV dysfunction for age, sex, EF, and pulmonary RVSP. And you can see in red, patients with severe TR do worse than patients with moderate or less TR. In this study, we were lucky to have access to an administrative insurance database, almost 500,000 of patients with heart failure. We find again increase in mortality with TR degree, but the good thing is that with such sample size, we could adjust for almost everything. And you can see that any subset, age, sex, MR, LV dysfunction, AFib, whatever you wanted to adjust for, there was an increase in mortality with TR. And it has been confirmed in this meta-analysis, 20 studies, more than 32,000 patients, and you can see that any adjustment was associated with increased mortality, RV dysfunction, pulmonary pressure, EF, MR, and AFib. And it was calculated that the increased risk of mortality in patients with moderate TR was 60%, and the mortality was multiplied by 3 in patients with severe TR. Second way to assess the independent prognosis of TR is to look at patients that have only TR. And we have 2 models. In this one, we looked at patients that have tricuspid flail as a model of isolated severe organic TR. Etiology were markedly different from mitral. 2/3 were traumatic, iatrogenic, or non-iatrogenic. And we have observed an increased mortality compared to expected and high rate of event. Another interesting entity is patient with isolated functional TR, which is likely linked to AFib and heart failure preserved EF. And patients with isolated functional severe TR in green have a worse outcome than patients with less severe TR in red. And the best way to assess the prognosis is to do randomized control trial. You fix the TR and you should see an impact on outcome. I will go back to that a bit later on my presentation. So how to manage patients with TR? In preamble, what is very important is that you need to be sure about TR severity. The patient had severe TR. You need to understand the mechanism and the etiology. You need to assess the RV size, RV function, and the RVSP. And we have 2 situations. First, you have only patient with TR, and 2, you are having a patient referred to left-sided valve surgery, and you are considering doing a tricuspid intervention at the same time. Let's go first left-sided surgery, and patients have severe TR. One example here, lady 53, she had a prior mitral valve commissurotomy with significant improvement in the mitral valve area, of course chronic AFib, and she comes back because she has a recurrent MS and she's in heart failure. Her mitral valve area is 1.3, at least moderate mitral regurgitation, mean gradient is 10. So for sure, there is an indication for doing something on the mitral valve. And here's a tricuspid valve. You don't need to be an echocardiographer. You see the large gap. You were seeing the large gap here with severe laminar TR. And so the question is that if I fix the mitral valve, will the TR get better? The answer is no. It's one of the studies I picked up. If you correct the mitral valve and the patient has severe TR, patient will remain with severe TR. So you need to correct the TR at the same time. And the guidelines are quite clear. If you're sending a patient for a mitral valve surgery, the patient has severe, as a primary or secondary TR, you must perform a concomitant mitral valve and tricuspid valve surgery. I mentioned this staging. TR is an important prognostic factor in that setting. You don't have to wait for these consequences. What is very important in the mitral valve surgery setting is to perform the surgery early before the occurrence of significant TR. You don't want to wait.
I realize I'm a little. Okay, awesome.
So severe TR, what about if the patient have only mild or moderate TR? Interestingly, if you don't have significant TR at the time of mitral valve surgery, a significant proportion of them will develop later on severe TR. And this development of severe TR is associated with a worse survival. Again, guidelines, what they are telling us, if you have mild to moderate TR and an enlargement of the annulus, you should consider performing a combined mitral valve and tricuspid valve surgery. Why is this annulus? The rationale for that is that TR is a late finding. And if you operate on patients that have annulus dilatation, you can prevent the development of TR. Two main studies, this one from Gilles Dreyfus, 311 patients referred for mitral valve surgery, and he performed a concomitant tricuspid valve annuloplasty in patients with an annulus more than 70. You never see that in echo. It was not an echo measurement. He was putting his hand inside the heart, the right, and if it was able to do that, meaning that the tricuspid annulus was enlarged, he was performing a concomitant annuloplasty. No difference in mortality, improvement in quality of life. Probably the most cited study in that setting is the one from Leiden. They had two strategies based on time. In 2022, 2024, they were performing a tricuspid surgery only if the patient had significant TR. You can see that you perform significant TR, you resolve the TR, is good. But if you have not significant TR, less than grade 3, and large annulus, patient will develop TR, and this development of TR is associated with RV enlargement, RV dysfunction. 2004, 2006, they had different strategies. They were performing TR surgery when TR was severe, or if the annulus was enlarged. And you can see that you are preventing the development of TR, and you have a good RV remodeling. Meta-analysis showing same finding, that if you perform a concomitant annuloplasty, you improve all-cause death and cardiac death. However, not the literature is in agreement. Large series of patients referred for mitral valve surgery for Mayo find again that TR severity was associated with outcome, and that if you perform an annuloplasty, you prevent the development of TR during the follow-up. However, no impact of mortality. The good thing is that now we have one randomized controlled trial from the CTSN. 401 patients referred for mitral valve surgery for degenerative MR that have either moderate TR or less than moderate, but a tricuspid annulus enlargement. And as a randomized annuloplasty or no annuloplasty. Endpoint was a composite endpoint of reoperation for TR, progression of TR, or severe TR or death. Population mean age 67, mostly male. If ejection fraction was mostly normal. 1/3 had moderate TR, and so 2/3 had less than moderate, but tricuspid annulus enlargement. The study was positive, and what was mainly driving the outcome was a progression to severe TR. And interestingly, it was mostly patients with moderate TR progressing to severe TR. Adverse event, not different between the two groups. For AFib, the same. What was interesting that the rate of pacemaker was markedly higher in patients that had a concomitant tricuspid annuloplasty, 14% compared to only 5% if you just perform the mitral valve surgery. So how we reconcile that the fact that when you do a surgery on the tricuspid side based on the annulus, you improve outcome in some series and not in others. There is a lot of confounders. First, how do you measure the tricuspid annulus? It's not always easy. How do you assess the TR grade? What is the etiology of MR? It's different between the different studies. Especially if you have a myxomatous tricuspid valve, we know that patient with myxomatous tricuspid valve has an enlarged annulus. It's not due to the consequence of the left side on the right side. It's just due to the tissue disorder. They have 42, 45 because they have myxomatous valve. If you perform mitral valve repair compared to mitral valve replacement, has not the same impact on the right side over 5 years, 10 years. Staying with a gradient of 5 to 7 compared to 2 with a repair, it's not the same at 10 years. Also at the stage that when you perform the mitral valve surgery, if you perform early in the course of the disease or in patients that are already AFib and PH. And also if you perform MACE surgery or not at the same time. So the question is, what we want to do and what we want to achieve is to prevent the occurrence of late severe TR. Here a patient that had mitral valve surgery 10 years ago, and she is referred back for severe laminar TR. So the question we should ask are, what are the predictors of late occurrence of late severe TR? You have the annulus, but it's not the strongest one. We have seen from the CTSN that moderate TR is one very important, and you need to assess these other factors and combine everything for the decision. Age, AFib, PH, rheumatic etiology, and mitral valve replacement. Is there a price to pay when you perform a concomitant tricuspid intervention at the same time? We look at that in this series from my prior institution in France. We look at all patients that had a mitral valve replacement over 2 years. Approximately 60% had a concomitant tricuspid annuloplasty, 40% remain with just a mitral valve surgery. You can see that patients that had tricuspid annuloplasty or tricuspid intervention at the same time had more severe clinical presentation, more rheumatic disease, more MS, more AFib, more severely symptomatic, more PH, but no difference in terms of death or major complications. Same was observed from this study from New York. Doing a concomitant tricuspid intervention when it's needed is not associated with a worse outcome. So we have seen the management of TR in the setting of concomitant primary MR. Now you have TR in the setting of secondary MR. We are missing a lot of evidence. It's very challenging. We have some evidence coming from the COAPT trial. So COAPT comparing CLIP to GDMT in patients, again, with secondary MR. A subset of this patient had a TR. If you look at patients with no TR, we find again that MitraClip was beneficial. And in the subgroup of patients with TR, the MitraClip was also beneficial. The problem is that we don't know what to do for sure. Mitral valve clip and TriClip, just a mitral valve and look at the tricuspid valve and maybe do a clip, perform no clip. The problem with COAPT, that patient with severe TR was excluded. So management of severe TR in the setting of secondary MR is very unclear. So we have seen TR in the context of left-sided disease. What about now you have only the TR? Another example, 83, she's high blood pressure, dyslipidemia, she's in chronic AFib, she's referred for heart failure, she's already on 125 milligram of furosemide and ACE. And the question is what we need to do on this patient. Just continue diuretics, send the patient for surgery, do a transcatheter valve intervention, or any suggestion. What the guidelines are telling us that if you have severe TR, primary or secondary, is a patient is symptomatic, and we can discuss what is symptoms in TR, or if the patient had an RV enlargement, in the absence of severe RV dysfunction and PH, you should consider a tricuspid valve surgery. The problem is how do you assess the RV, what are the thresholds? It's a very vague recommendation. What are we doing in clinical practice, in real world? We look at that in this administrative database. We collected all patients admitted in 2014 and 15 in France with a diagnosis of TR. 70,000 of patients, mean age was 75, 22% had prior cardiac surgery, MR was common, and heart failure as well. 20% of this population only underwent an intervention within a year. Interesting, half of them were not TR related. And if you look at patients that were referred for mitral valve surgery, so they have both MR and TR, in 1/3 of the patients, the TR was neglected. It's quite surprising. And in the patients that were conservatively managed, mortality in hospital was high, 5%. 1 year, 18%. And at 1 year, 1/3 of the patients were either dead or readmitted for heart failure. And it was true overall, but also if you had a prior left-sided intervention or if you had isolated TR. In contrast, we do very few interventions for TR. In this study from the US, you can see that there was an increase in the number of tricuspid valve intervention performed in the US from 2004 to 2013, but the absolute numbers are ridiculously low. And mortality remained the same all over to 2004, 2013, around 9%. We look at that again in France. Only 20 patients underwent an isolated tricuspid valve surgery in France, 70 million of people per year. And mortality was again the same, 10%. To understand a little bit more of that, we asked 12 friends in France to collect all the tricuspid valve surgery that they were performing in their center between 2007 and 2017. We asked them to focus particularly on isolated tricuspid valve surgery, but they collected all the numbers of all tricuspid surgery. The good news is that there was an increasing number of tricuspid valve intervention, but mostly at the time of mitral valve surgery. And isolated tricuspid valve surgery remained very steady all over the years. We find again, in hospital mortality, we had 466 patients that had isolated tricuspid valve surgery. Same magical number, mortality was 10%. Interestingly, there was a wide difference in mortality based on the etiology or underlying cause. 16% if you had a prior left-sided surgery, 5% for endocarditis. But if you adjust for the clinical presentation, etiology was not anymore a predictor of outcome. This means that the clinical presentation was driving the outcome, not the etiology. So clearly, patients with TR are undertreated, referred too late in the course of the disease. Like everything, timing is key. And for that, we have developed the TRI-score. Using the same population, we developed a score that was predicting in-hospital mortality for isolated tricuspid valve surgery. 8 parameters. You have the clinical, 8 of course, but the clinical presentation, UOHI class, functional class 3-4, heart failures, and dose of diuretics. You have EF, and you have the consequences on the kidney, the liver, and the RV. And the score is from 0 to 12. And we have observed again that the mortality associated with functional TR was not due because they had functional TR or a prior left-sided surgery. It's because they had higher TRI-score, much later presentation with a much higher TRI-score compared to patients referred for an organic TR. We have developed the TRI-score calculator and put that online. You can use the website. We have now, with no fees, an app that you can have on Google or on Apple. What is important is not to look at the absolute number of mortality, is to have some categories. If your score is between 0 and 3, you are at low mortality risk. 4, 5, intermediate, and more than 6, high TRI-score. I'm happy to say that now more and more people are using the TRI-score, and Abbott has put the TRI-score now on their website and recommend its use for risk stratifying patients with TR. So I mentioned earlier that if you want to prove that TR is impacting the outcome independently, you do a randomized control study. You correct the TR, and you expect that by correcting the TR, you will improve the outcome. We had few observational studies. This one from Taramasso showing that if you do a transcatheter repair with a clip, you have a better outcome compared to the medical group. Contrast, this other study comparing medical therapy to surgery, no difference in outcome. So the first randomized control study that we have is TRILUMINATE. TRILUMINATE has randomized patients with severe TR, estimated an intermediate or high risk for surgery. It's not clearly mentioned how they assess that. It's a randomization 1-to-1, and they use the TriClip system. Inclusion criteria, you need, of course, to have severe TR, to be symptomatic, to be on GDMT, at least diuretics stable. And again, this consideration regarding the risk. They exclude patients with severe LV dysfunction, severe PH. And of course, patients that were not suitable for performing a clip. Composite endpoint for the primary endpoint: mortality or tricuspid valve surgery, heart failure, and quality of life. And the study was positive for the primary endpoint with a win-win ratio of 148. However, what was driving the outcome was mostly quality of life. The conclusion was performing a clip in patients with TR was efficient, you reduced TR, and was associated with an improvement of quality of life. Second trial, TRIFAR. What is good in TRIFAR is that in contrast to COAPT and MyTRIFAR, we find the same results, which is good. No controversy with the US. Again, composite endpoints of cardiovascular event and quality of life, UOHI, and this kind of odd way of assessing improvement. So if you had mildly improved symptoms, you was considered having an improvement in quality of life. Again, study was positive for the primary endpoint with a significant p-value. And the third trial did not compare repair, so the clip, compare the replacement using the Edwards Evoque device. They randomized 2-to-1 device compared to diuretics, continuing medical therapy, and again, it was positive. So industry was claiming that it's a huge success, all the studies were positive. Reality was a little bit quite more sobering. First, we are claiming that TR is a silent killer. We have seen that all observational studies showing that TR is associated with heart failure and mortality, and you have 3 randomized controlled trials not showing that. Triluminate, no difference in mortality, no difference in heart failure hospitalization. Same for TRIFAR. If you look at major cardiovascular event, no difference between the 2 arms at 1 year. TRISCEND-2, exactly the same. No difference in mortality, no difference in heart failure. One explanation has been that maybe 1 year is too short to see the impact of correction of TR on outcome of the hard endpoints. So at ACC, we had a small note of optimism with the publication of the result of Triluminate at 2 years. And what they found is that in the TriClip group, you have an improvement in heart failure readmission. It was a mean cumulative function. If you look at that, if you have the device, you have lower rate of event, especially in the second year. What is important is that after 1 year, you have the right to have the crossover, meaning that the control group could be treated with a clip. 2/3 had a clip after 1 year, 1/3 remain under medical therapy alone. However, I'm a little bit surprised by the type of analysis that they have done. If you look at the New England paper, the 1 year survival, 1 year admission for heart failure is the time for the first event. And you can see in blue that clip is doing a little bit lower. It's not significant, but a little bit lower. Here, they are only providing cumulative event. They're not providing the same analysis. And at 1 year, you had the opposite. It means for cumulative, you have the control group doing, the clip doing a little bit better. And they are not providing the same time to first event with the Kaplan-Meier. So we can be a little bit suspicious saying that maybe it was not positive. So for the tricuspid valve intervention, what we can say that we have a possible benefit on quality of life, but there is no sham. If you do an intervention and you ask a patient, do you feel a little bit improved? Maybe, yes, and it's positive. Heart failure, we need to have more in-depth analysis from Triluminate. What are the other reasons that we can discuss to explain again this discrepancy between all observational studies showing an impact on mortality, impact on heart failure, and the randomized control trial being neutral? One is that the contemporary natural history of TR, medically managed, is maybe more complex, and I will show that. Mortality at 1 year in Triluminate, TRIFAR, and TRISCEND-2 is very different, from 5% to 15%. So different populations have been enrolled, and we don't know for sure what is the real natural history of this subset. 2, it's like everything, maybe not all patients benefit from a tricuspid valve intervention, and how to identify the good one. And 3, there is no clear mention about impact of residual TR and how you define that. To address some of these issues, we have built, relying on the first one we did in France, a Tricuspid. Now it's international. We have adult patients with isolated functional TR, and we have the TriScore in all patients. And we had 3 groups: patient conservatively managed, patient treated by surgery, repair, replacement, and patient treated by transcatheter. In that cohort at the beginning, we had only tricuspid valve repair. At that time, we had 2,400 patients, 33 centers, 10 countries. And what we have seen first is that the TriScore has been designed first to predict in-hospital mortality for isolated tricuspid valve surgery, but it's also a very good predictor of the mortality of patients medically managed or who undergo a transcatheter valve intervention. You can see that the outcome, the mortality, is increasing with the TriScore. We can discuss about calibration. Has not been designed for being calibrated to predict the outcome of these 2 subsets, but in terms of discrimination, it's very good. If you have high TriScore, whatever your treatment, your mortality is high. Second important finding is that when you take the registry cohort overall, no difference in outcome in terms of survival. If you do medical therapy, surgery, or transcatheter, overall, no difference in mortality. But if you divide your population based on the TriScore, you can see low TriScore, less than 3, you have a benefit of the intervention. If you have intermediate, there is a trend, but not significant. And if you have a high TriScore, more than 6, whatever you do, mortality is the same. And for the surgical group and the medical group, we have a much longer follow-up. And so we looked at the outcome up to 10 years, comparing surgery to medical management. You can see in blue and gray that patients that had mitral valve surgery repair or replacement in the low TriScore, less than 3, had a better outcome than patients conservatively managed. In the intermediate TriScore, if you do a repair, you have a better outcome. If you do a replacement, you have a worse outcome. Again, it's the performance of the type of intervention. It's not randomized. And there is some reason why you perform a replacement compared to a repair in some patients. Again, high TriScore, up to 10 years, whatever you do, replacement, repair, same outcome. And after that, we look at the impact of residual TR. You can see here in pink that patients with residual TR defined as more than mild to moderate have the same outcome than patients on the medical group. Maybe an even harmful effect in the high TriScore. And we look at that a little bit more in depth. We compare the outcome up to 2 years in the transcatheter group of residual TR. You may not know, but the grading of TR is a little bit odd compared to mitral regurgitation. You have only 3 groups: mild, moderate, and severe. In MR, we had 4 groups: mild, mild to moderate, moderate to severe, and severe. Why it's different? Not for sure. But we find again that patients with moderate residual TR do worse than patients with no or mild, but slightly better than patients with severe. But we thought that it was probably an heterogeneous population, and we wanted to have more granularity like we do for mitral. And we asked the centers to provide an evaluation of this entity, and we find it's quite heterogeneous. 2/3 of the moderate had been graded mild to moderate, 1/3 moderate to severe. And the outcome of patients with mild to moderate is the same than patients with no or mild residual TR, while the outcome of patients with moderate to severe is the same than patients with residual severe TR. And it has a marked impact on the trials. In the 2 randomized trials using the clip, moderate was considered as a success. And they had around 13% with severe residual TR. But if we assume the same distribution, that among the moderate, you have 1/3 that have moderate to severe, 2/3 had mild to moderate, you end up having 25% in both trials that have significant residual TR. And if you have poor result of the intervention, it might explain why you don't see a benefit on outcome. And based on that, we have suggested to refine the classification of TR and mimic the one for mitral regurgitation: mild, mild to moderate, moderate to severe, and severe, in addition to the more granularity that has been suggested by Rebecca Ann to subdivide severe in massive, severe, massive, and torrential. The meaning is that it's a continuum, and this group is too heterogeneous to keep all the patients in the same basket. So what next step for trajectories? What we would like to do is increasing the number of participating centers and have more real-world participation. So we have extended to Canada and the US. And we are looking for centers in Asia, and we have Australia on board. What we would like to have more is Eastern and Northern Europe, more Asian centers, and South America. We are collecting longer follow-up of patients with transcatheter valve intervention. We are increasing the granularity of data. We are collecting more about the etiology, the pacemaker, the position of the pacemaker. And we are very interested in understanding better the natural history of patients medically treated. Again, mortality at 1 year is very different between the three trials. 5% in TRIFAR, 10% in TRILIMINATE, 15% in TRISCEND-2. So this medical population is very heterogeneous, and we need to characterize the outcome of this patient a little bit better. And one way, as I've shown you, is probably to have the TRI-score. If you have the TRI-score, it's not only predicting the outcome, but it's also a way to characterize how severe or how advanced is your population with TR. Now we have almost 50 centers on board, and our goal is to reach 10,000 patients at the end of 2025. So to summarize the three situations, primary MR, and you are considering doing something on the tricuspid valve. If you have severe TR, no doubt, you need to do mitral valve surgery, tricuspid valve surgery. I think moderate TR, irrespective of the tricuspid annuloplasty, should be corrected. If you have no mild TR, you need to look at the annulus, but it's probably not the main predictor in my opinion. And you need more critically to look at if you perform mitral valve replacement compared to a repair. If the mitral valve etiology is rheumatic, if patient is in AFib, have PH, and is in congestive heart failure. If you have these findings, you need to be much more aggressive in correction of the tricuspid side at the same time as the mitral valve. In the setting of concomitant secondary MR, secondary TR, we don't know, and that's where the heart team is really beneficial. When you look now at patients that have only isolated severe TR, we have the guidelines, quite vague. What is for sure is that to get a benefit, you need to intervene earlier in the course of the disease. And for me, when I start diuretics, when I start increasing diuretics, it's a trigger, and I ask myself, should I consider a tricuspid valve intervention? Same when you have serial echocardiography, when you see the RV enlarging, it's a trigger for considering an intervention. And we have summarized that in our viewpoint that has been published in JAMA last week, how to manage this patient. You need first to assess the patient, the clinical stage, futility, frailty, and after that, you need to combine two independent parameters. First, the TRI-score. What is your risk score? Low, intermediate, high. And you assess the anatomy. What is your likelihood of having good success with a tricuspid valve intervention? If you have a low TRI-score, you can consider both surgery or transcatheter intervention if you have a high likelihood of good procedural success. If you have intermediate, probably transcatheter intervention is probably better, especially if you have a high likelihood of success. And if not, you can consider surgery, especially if you can predict that you will be successful only with a repair. And when you have high TRI-score, we don't know. All the evidence is showing that you have no impact on mortality for sure. And we need to be transparent with the patient. Why are we doing the intervention for? Probably or possibly for quality of life, heart failure, maybe. Definitively, we have no proof that we're improving mortality. I stop here, and I'm happy to answer any question you may have. I think we have to unmute something.
Yeah, right here. Okay, thank you very much for that fascinating talk. It was a very important topic. We'll open up the room to questions, and I will open up the chat box as well and see what we've got here.
Hi, you alluded to this, so I find, measuring the tricuspid valve annulus on echo, everyone does it a little differently. When you're saying the 4 millimeters at your institution, are you doing that on transthoracic with a focused RV view? Or are you doing this at the time of the OR based on the TE? Because I see both, and I'm just curious kind of what you would suggest.
The 40 is not coming from me. It's
Fair
from the
enough, fair
guidelines.
enough. Sorry.
It's a very important question. There is no, if you look dig into the guidelines, no recommendation how to do it. What we have done is comparing transthoracic to 3D, TEE, and all the views were giving relatively similar results. The four-chamber view was probably the most doable and the most reliable. We tried to tilt to have the maximal view of the tricuspid annulus. If you do so, you're underestimating approximately 5 millimeter the long axis that you get by TE because it's an oval shape, but it's quite reliable. So four-chamber view, tilting to get maximum RV diameter.
I have a question in the chat there. Now two questions in the chat.
What about device and use TR? How common? And what should be done? Very common, yes. It's EP are a nice guy with us. It provides a lot of TR. What should be done? I think it depends of. So you have two settings. First, if you have the lead which is innocent, you have a patient with functional TR and patient had a pacemaker for another reason, but the lead is not causing the TR. In that setting, I think we should do exactly the same. When the lead is causing the TR, if it's very early post-pacemaker, I think you can replace the lead. But if it's late, usually even if you remove the lead, the valve is thick and you have no impact on TR. So the strategy is probably to remove the leads and try to do a transcatheter intervention or surgery. And if it's the lead, if it's innocent, you do same than a regular TR. But it's impacting visualization. It's impacting a lot of things. But don't expect that removing the TR, if the TR is due to the lead, will improve the TR. Usually no.
Amel?
As you or like animals and CT, not only like like disease diagnosis and staging. And how do you see the role of this imaging course?
No, it's a very important question. CT, we don't use that mostly before intervention for TTVR. I'm using more and more the MRI for the RV size. RV function, you have the same problems as us because you have a decrease afterload, so you're overestimating the EF. But I think it's very challenging to assess RV size and RV function by echo, and combining different methods to follow up the patient is very important. So I try to do now at least once a year or once every 2 years an MRI for the patient with TR for whom I continue conservative management. CT I don't, but I think you can have also very good information regarding RV size and with CT as well. So we need to promote that. Echo is challenging. Following a patient conservatively only with echo, I think it's probably a little bit too weak.
Next question on the chat there.
Would early change to the liver? So the impact on liver, yes. We know that, for example, ascites is associated with a 30% mortality if you perform a surgery. So it's definitively not something you want to wait for. If you have a bilirubin, it's accounted into the tri-score. So probably if you have a patient with TR that start to have impact on livers, mean that it's already an advanced disease and you need to consider the treatment now. Do you feel surgeons should be more aggressive? It's coming from a surgeon with TR surgery at the time of mitral valve surgery. Yes, for sure, definitively. But I think we need not only to rely on the annulus, and I think the other parameters, AFib, pH, replacement, and rheumatic etiology are critical.
Questions in the room? If not, thank you so much for coming out.
My pleasure. Thank you.